I was walking through the all-ceramic department the other day and noticed a case that was sitting off to the side because the doctor had to be called because we needed another impression taken. And when we look at this impression, we've got a single unit used in a plastic double arch tray. We usually say that when we use a plastic tray, we want a stiffer material so that it won't deform much, as opposed to some of the metal trays that I like. I like that Clinician's Choice Quad Tray Extreme that you've seen before, which is the disposable one, and I like the Trio Tray Pro, which is the one from Triodent that Ultradent now sells. And those are both metal and extremely stiff, so you can use any material you want, but that's good stiffness. I'm pretty confident in that, squeezing that's going to be okay. So as we quickly look at this, I'm always thinking, what was the dentist thinking as they looked at it? That mesh actually looks a little thick for me. I can never see that much mesh when I have patients bite into our double arch tray. I want the thinnest mesh possible. I think the Clinician's Choice is like 10,000ths of an inch. And that looks thicker because on my impressions, I've never quite seen that much of the mesh exposed where the impression material is just kind of gone. You know what I mean? You've got these spots over here where we just have large areas here where I don't see any green. I mean, it's okay to see a little spot here and there, but I'm just seeing a lot of interproximal mesh. And the other thing that I notice is this patient has wisdom teeth, and this is always something that's iffy. When you look back at that third molar, you can see the patient was biting on that tray. And so the tooth comes all the way back to here, and then you can see over on that corner, like on the distobuccal corner, you can see the tray showing through right there. And that is definitely within the perimeter of where that tooth is. And so we know that this probably kept the patient from biting all the way together, so to a certain degree. Now on this side, we still see some mesh, but it appears as though there's a thin layer of polyvinyl material over the mesh itself. Margins look good. I can see the margins. I can see some material beyond the margin, which is pretty awesome. That, of course, is something that we look at and want to see. So from that perspective, just looking at how accurate are the margins, how accurate is the impression in this area, for the prep tooth, it looks really good. But I have some questions because the patient bit together and appears to have hit the tray on the wisdom tooth. So here's the restoration, and it has come back from the doctor at this point. You can see where the mark is, and as we zoom in with our gorgeous TV camera, spoiler alert, I think you know how this one ends. During cementation, when the patient bit down, it went crack, and this is where it came apart. And this is a lithium germanium silicate crown. And so you can imagine if the patient was biting down perhaps on the impression tray and being held apart a little too far, and then the crown goes to be cemented in the mouth, and boom, we have the bite all of a sudden. The crown's now way too high, and the patient really cranks down on it. It could fracture. Now, one of the things that I noticed when I measured the crown with calipers is that in the area where it fractured on the occlusal surface, might be easier to see on the larger piece, we were down to 0.5 of a millimeter, and a lot of 6/10 spots and a couple 7/10 spots, and that's fine for solid zirconia like Bruxer, but for something like this, for one of the lithium germanium silicate, that's just too thin. And if you look at the model work, it appears as though there's enough room, and that does look like enough reduction. And it's certainly going to be enough reduction if the patient bit on the tray, and so now the models are farther apart from each other than they really should be in the patient's mouth. Because that looks like 2 millimeters. That looks like you could drive a truck through there. And clearly, when we look at the restoration, it's not that thick, and clearly the restoration fractured when the patient bit into it. So we're always talking about margins, but let's just say it again to say it. We want to make sure when we look, especially when somebody's got wisdom teeth, that we don't have interference on the most posterior part of the tray, because it could lead to exactly this, where you get a great impression of the preparation and a crown that fits really well, so well that you're going to go ahead and cement it, and then the patient bites together and you hear a sickening crack sound, and you're probably thinking, well, I thought these were high strength all ceramic materials. Well, they are, but as soon as you get under a millimeter, any of the lithium materials are prone to fracture under a millimeter. If you get under half a millimeter, even the zirconia ones are prone to fracturing. The only thing that will not fracture at any thickness, of course, is cast gold, a wonderful material that everybody in dentistry knows is the best material we've ever had, and every patient who's ever seen it thinks it's the ugliest thing that they've ever seen. So I don't see myself getting into this issue because I will not place either of these materials on molars. I am just a solid zirconia guy on the molars. On the bicuspids, I can go either way. I'll do solid zirconia if I see a lot of wear on the anterior teeth or a broken PFM or another kind of broken restoration in the posterior. Then I will do solid zirconia like Bruxer on the bicuspids as well. If not, if everything looks good and not a lot of signs of parafunctional habits, I'll put Emax on these teeth or Obsidian and all the way around the front. So really, I'm a zirconia guy in the posterior areas of the mouth, and then I'll use something not quite as strong but way more aesthetic, like the Emax or the Obsidian on the anterior teeth. Why would you put something like this? Why would you put a weaker and better looking material on a first molar? I don't know. I mean, I just never do that. I always put the zirconia. It looks good enough today. 2 years ago it was pretty ugly and kind of scary, but today I'm going to use solid zirconia on these posterior teeth. And I had a dentist asking me about this at a lecture last week, saying, well, can't I put it on there? Well, you can, if you use depth cutters and you know that you have at least a millimeter of reduction, preferably 1.5 millimeters reduction in case you have to go in and occlusally adjust the crown when the patient bites down. So my rule number one is zirconia only on molars, solid zirconia only on molars, bicuspids. It could be either one depending on the wear patterns and if there's any other broken restorations in the mouth. And then day in and day out, I'm going to be using Emax or Obsidian on the anterior teeth. You've seen me use Bruxer on anterior teeth before, and I will if there's a lot of wear or we're doing more than one unit. Or there's some other reason. But otherwise in the anterior, these materials do well here. It's just on the molars with all the bite force where that happens. And again, not doing a lot of single unit PFMs. For me today, PFMs are something that are used for bridges, but I don't use them anymore for single tooth restorations.